My name is Mahmood Razavi. I am the director of Clinical Trial Center at the St. Joseph Heart and Vascular Center in Orange County, California. Well, there's a large list of unmet needs in patients with peripheral arterial disease because the treatments are multifactorial, especially in patients with CLTI who have the most advanced form of peripheral arterial disease. Every aspect of their treatment has to be optimized, including medical therapy, lifestyle modifications, and revascularization, pain and infection control. All of those have to be optimized to improve limb salvage. There is a group of patients with critical limb ischemia that have no revascularization options, or revascularization options have been exhausted. These patients have recently been the interest of several studies, including the one that we presented at VIVA this year. That is, how do we improve blood flow in these patients to preserve limbs or enhance ulcer healing or healing of non-wound ulcers under toes and heel and legs. The patients that were selected, this was a very small study that took advantage of the therapeutic effect of ultrasound. This is called therapeutic ultrasound. Therapeutic ultrasound has been shown to cause not only vasodilation, but also has been shown to cause or improve macrovascular as well as microvascular collateral formation. Most of this data were in the animal studies. However, there are studies in Japan on patients with heart disease that they looked at myocardial perfusion, which was increased by 20 to 50% after applications of therapeutic ultrasound. So we decided to test and see if there was such effect in patients with critical limb ischemia. So that meant that initially a device had to be developed that is appropriate for these patients. So a sleeve was made with several phased arrays individually implanted into the sleeve, with a focus of the acoustic field being on the posterior tibial and anterior tibial arteries. This was initially tested, on all of us, and we just put it on for comfort and for optimization, and then we applied this to 12 patients under obviously an IRB approval. 12 patients with no option patients were included in this study. The protocol is actually was designed to test patients' comfort and acceptance of the therapy, because they would have to wear it for, the way we tested it was about 90 minutes at a time for 5 to 6 sessions a week. And this continued for about 6 weeks, because collateral formation is a slow process. So you have to give therapeutic ultrasound time to develop collaterals. And as these types of studies are ongoing, one of the features that we knew existed and we experienced in this study is that, how do we actually measure the therapeutic effect in this patient population? The tools to measure improvements in perfusion and flow to the limb are very limited. So we decided that we test everything that there is in these 12 patients. So we tested them by a device called FlowMet, which acutely measures, it's a laser Doppler speckle analysis of blood flow on the toe. So everybody was measured using FlowMet. We also measured tissue oxygenation by a device called Clarify, which also uses a spatial frequency domain to measure oxy and deoxyhemoglobin in the tissues. We use toe brachial indices, which is a standard. We also use Doppler and transcutaneous oxygenation, and a quality of life questionnaire in these patients. So multiple sort of tools to measure the changes. Now, the hypothesis was that we can, through vasodilation and increase collateral formation, improve perfusion. The problem was, how do we measure that perfusion? And so that was an interesting discovery and finding for us. The major finding of the study is that the therapy was very tolerable and acceptable to patients. There were no issues. Obviously, it's an external sleeve that we wear, that patients wear on the calves. Nobody experienced any difficulties or issues. There was one episode of a patient who had a transient pain when the ultrasound application was turned on, which went away. There were no other issues. Everybody tolerated the treatment. Everybody came for all treatment sessions. And what we found is that there were some acute and some subacute changes. Acutely, we did find significant improvement in blood flow as measured by FlowMet. That, on the average, it was about 180% improvement in blood flow measured at the toe from the beginning of a treatment to the end of the treatment. The changes, there were also changes seen in tissue oxygenation as measured by Clarify. There was, the biggest difference was seen comparing the baseline to the end of all the treatments, which was about 6 weeks later. There was a 17% improvement in tissue oxygenation. So that's probably due to more than just vasodilation. The acute changes that we saw during therapy and from beginning to the end of a single session, that I referred to as we measured by FlowMet, is almost certainly due to vasodilation, because you can't form collaterals that fast. But the changes that were seen from baseline to the end of entire treatment several weeks later, and that was changes seen in tissue oxygenation, that is likely due to collateral formation. Now, that's hard to measure in humans because we didn't do angiograms in everybody to see what is going on. By the way, as I mentioned, all of these patients that had multiple failed revascularization procedures. Now, the one other thing that we did see, we saw improvement in laser Doppler of about 39%. That difference, however, was not statistically significant because of a small number of patients. And the last thing I want to talk about is the changes seen in TBIs. There was actually not an improvement in TBI, but a slight drop of about 5%. And we think the reason for that is the therapeutic ultrasound causes a regional localized vasodilation without a compensatory compensation of body and blood pressure. So the blood pressure systemically remains the same locally due to vasodilation drops. So you would expect the toe pressures to decrease. And that's what was seen here. Well, this was, again, the objective here was twofold. One, would the patients tolerate it? Number two, is the therapeutic effect measurable by any of these means? And we found that number one, there were no safety issues, and that the patients tolerate the procedure, and in fact motivated, especially this patient population. Number two is that we honed down on how do we measure that therapeutic effect. And it looks like there are changes in some of these tools that we use to measure that we will be using in the near future. Now, there is a sham-controlled randomized trial on the line using this technology to look at patients with diabetic foot ulcer and perfusion problems of the limb. And so that study will begin soon.